coronary circulation. Okay. Studying coronary circulation is very important for you. Why? Go through. So you must know the normal physiology of coronary circulation as well as pathological physiology, pathophysiology of different diseases that are related to coronary circulations. Okay, because there are number of deaths because of this disease of the coronary circulation, and the death rate of death is very high. 1/3 of the total deaths in the globally, it is because of coronary. One of the important characteristics of this circulation is that though it deals with blood, pumping of blood into circulation, into blood vessels, to supply the blood to the different parts of the body. But it cannot use this blood directly for its own nutrition, for its requirement of oxygen. So why? Because the wall is thick. Blood cannot diffuse directly into the inner part of this or to the outer part of this. So that's why you need a special circulation. And this circulation is called coronary circulation. And another feature of this, the heart has got 3 layers. The outer layer is epicardium, then myocardium, and innermost layer is endocardium. Okay, so coronary circulation, for coronary circulation, main vessels, main arteries, they remain superficially, that is in the epicardium. And they produce branches. Suppose this is the heart. So they will run along the epicardium. From the epicardium, several branches will be coming inside. They will supply through smaller arterioles, capillaries to the myometrium, and myometrium, then endometrium. Okay. The endocardial surface is very critical. Why this endocardial surface is? We will be knowing. This surface, this layer, endocardial layer, is very susceptible to infarction ischemia. Why? You will come to know. So for that purpose, it has developed certain change to cope up with the situation. Number one is the innermost layer, 10 mm layer of the endocardial surface, can obtain significant nutrition directly from the blood. That is, the blood is, so this is the innermost surface, here is the blood, so they can take their required oxygen and nutrient directly from there. Only this much, very small thickness. Okay. Coronary circulation, it is comprising of arterial system, venous system, and lymphatic system. The arterial supply is mainly made by two important arteries. What are these? Left and right coronary arteries. Okay. These two coronary arteries, from where they originated? There is aorta. Suppose this is the beginning of the aorta. So at the beginning there are valves, aortic valves, and they open outside. When the blood tries to enter into the ventricle, the cuffs close. So at the root there are valves. These valves are semilunar valves. Let us see how they originate. This is the root of the aorta, and this is the wall, atrial wall. So this is the orifice through which root of the aorta So at the root, there are three cusps, semilunar cusps. Okay, so why it looks like this? The aorta, I dissected longitudinally, then make it flat. Now it looks like this. Okay, so these are the three lips, and this cusp is like this: open, close, open, close, open, close. So here is the wall. So when they when they open, they tend to close this aperture. Because this aperture is at the back on the wall. When these valves open, when blood enters into the aorta, so the flaps will be coming close to the wall, so they may cover these two apertures. These apertures are opening of left and right coronary artery. Okay? This position is actually, this is the aorta. This is the root. So from the root, this is left coronary artery and this is right coronary artery. This is the root of the aorta. They are originated from these apertures. Now it is more clear to you. These are having what? These cups are having a sinus. How they close? How this valve close? Blood is entering, they are opening, going towards wall, closing towards wall. Now when the blood ventricle undergoes distension, means diastole, then this blood, aortic blood, will try to come back to the ventricle because of the pressure in the aorta, pressure of blood in the aorta. So now this blood will flow, try to flow. So because of this, these sinuses will be filled up with blood and they will close. So now they cannot enter. Okay, but if they are closed, but these orifices are now open. Orifices of what? Right coronary artery and left coronary artery, these are open. So because of this pressure, this blood will be entering into these vessels. So we can see, we'll be seeing, they actually, in other organs, blood is supplied mostly during systole. During systole, blood is ejected in the aorta. This blood is through aorta is reaching to the body, and during diastole, no blood is flowing, no blood is coming into the aorta, so no blood is flowing. Okay, again during systole, again blood will be coming, it will be supplying. So only during systole we get the blood supply, but during diastole we don't get. But here it is opposite. During diastole, the heart, particularly the left ventricle, will get most of the or adequate coronary blood flow. Adequate flow will be getting during diastole, not during systole. There are other reasons I'll explain. So let us see about their course. The course of coronary arteries, course of coronary veins is not very important in physiology. This is important in anatomy. So you can expect questions in anatomy, but most unlikely you may not get questions regarding the course of how while passing along the surface of the heart, how it is producing, what are the different branches. Even then, I will now explain it to you. So first, start with this. This is what? right coronary artery. So this is the root of the aorta. So from here it is originated and passes through this is the auricle. This is the auricle. What is auricle? So this is auricle and this is the pulmonary trunk. So it passes through in between the space and passes along the coronary sinus. Passes along the groove, atrioventricular groove called coronary sinus. So it passes along this groove and turns here to the back, and it will go to posteriorly along the groove, along the coronary sinus. Now while coming down, it produces several branches. What are these branches and where these branches are going? Where they are supplying? Now see, this is the first branch, going to SA node. Going to SA node, that's why it is sinoatrial node branch of artery. Okay, and the second branch is going to where? This is the conus area, right conus area. So this is the conus branch. Then this will go to the atrium, mostly to the right atrium, and partly it will supply, this branch will supply partly to the left atrium at the back. Means this will supply this area and part of the will go to back and supply the left atrium. Okay. Then what is this? It is right anterior ventricular branch. So this is the right, this area it will be supplying. What is this branch? Right anterior ventricular branch. Then what will happen? It will produce two main branches. This is the marginal branch and this will go towards the back. This is called posterior descending artery. This one is posterior descending artery. Posterior descending artery. This PDA, in short we call it PDA. Most of the blockages we do angiography. When we go for angiography, first you will find some patient is having hypertension. Okay, he is having hypertension. Okay, and next part you have to know why this hypertension. What is the reason of this hypertension? Are there any peripheral obstruction? So what you will do? You will go for test of lipid profile. So lipid profile, if there is high lipid profile, high triglyceride level, high cholesterol level, high LDL, low VLDL, low HDL, high VLDL. So these are the indicator of, that is, blood is having high amount of, means dyslipidemia, high amount of lipid. So they may become deposited along the wall of the blood vessel and they may develop atherosclerosis. They may develop atherosclerosis. Means it may narrow down the lumen of the blood vessels. As a result, flow through the vessel will be less. When this flow through this vessel become less, we feel pain. So you obstruct circulation of your leg by occluding this area. What will you do? You feel some numbness and then pain. So what is the cause? There are several factors. End products are formed, like P substance, kinin, lactic acid. These will be deposited. They will create pain. And this pain is called angina pectoris. Same thing can happen anywhere in the body, but if it happens in the heart, it is called coronary atherosclerosis. So in such case, when the blood vessels will be narrowed because of atherosclerosis, but not completely blocked, so you will feel, the patient may feel pain. This is called angina pain. So this pain is such that when you will be doing give certain exertion, or you become excited, or the patient become when walking along with friends, but he cannot keep pace with the friends. So always he tries to remain behind and tries to take rest. So in this case, he feels heaviness in the chest, or there is radiating pain. So these are the symptoms of angina. These are the symptoms of angina. That means there is some obstruction in, or some vessels, coronary vessels has been narrowed. Okay, now next part, when the patient is giving such symptom, then you may think, or you may doubt that he must be having some obstruction in the coronary circulation. Then what you will be doing? You will be advising electrocardiogram. Okay, so then electrocardiogram will be, from electrocardiogram you may get that the patient is having ischemia. Ischemic heart disease means narrowing of blood vessels of the heart. So which part? Either it is anterior part, or in the lateral part, or in the septum, or in the apical part. This can be diagnosed from the ECG, which part is affected. Next part is then I have to, sometimes some patient may not have ECG is clear, but he is during exertion or exercise, he is giving symptoms. Then what to do? Then the patient is advised to go for treadmill testing, TMT. Means he will be running on a treadmill, and during this time ECG will be done. So during this time, when exertion is given, heartbeat is increased, then the problem may come out. This angina can come out. So that will confirm that yes, this test is positive for angina. Next part is, I have to identify. Next part is, it is confirmed there is some blockage, but where it is not known. Now I have to know where the blockage is. Then what you will be doing? Then the patient will undergo angioplasty. What is angioplasty? So one catheter will be inserted through aorta up to the root of the artery, aorta, up to the root of the aorta. Then it will be sent either to the left coronary artery or to the right coronary artery, and here it will inject some radio-opaque dyes. So this dye along with blood will be circulating through these blood vessels, coronary blood vessels, and these are monitored, how this dye is passing. So you can see catheter is inserted, then there is a balloon, the balloon will expand, the blood vessel will be dilated, then what? The balloon will be retracted, and a spring-like structure will be left there. So now it will not be constricted, will not be able to constrict. So there will not be any more obstruction. Now it is okay. So this way this blockage can be removed. This is called angiography. First you have to, by angiography, you have to find out where the blockage is. Then through balloon angioplasty, you can make it dilated forever. The right coronary artery, the anterior segment, while remaining in the anterior side, it produces, these are the branches. Sinoatrial artery, then right coronary artery, then right anterior ventricular branch, then right marginal artery, then the atrial branches. So these are the anterior part, and the part that is going posteriorly, they will produce this. Two branches, one is right posterior ventricular branch and the posterior interventricular. It will be supplying, having branches, one will go to septum, interventricular septum, another will go to AV node. Okay, so these are the branches and the area RCA is supplying. Now, what are the areas covered? These RCA, right coronary artery, it supplies SA node, it supplies AV node, it supplies complete right atrium and part of the left atrium, greater part of the right ventricle, and small portion of the left ventricle posteriorly, and posterior 1/3 of the intraventricular septum. The septum in between both the ventricles, first 1/3. Rest of the part, rest 2/3 will be supplied by the left coronary artery. And whole conducting system. The heart is beside this myocardium. The heart is having another type of tissues. These are specially modified muscle cells, cardiac muscle cells. Their function is not to contract. Their function is different. What is their function? Their function is, these tissues are called junctional tissues. These junctional tissues are two types. One type is pacemaker tissue. Another type is conducting tissue. One part is pacemaker tissue. That means it can generate spontaneously, this pacemaker tissue can generate spontaneously cardiac impulse. And the other conductive tissue, their function is to conduct those impulses produced by the pacemaker cells. There are three groups of pacemaker cells. One is SA node, another is AB node, another is bundle of His. These three group of pacemaker cells, they can produce their own impulse. No need of external stimulus, no need of currents, no need of any other stimulus. They can generate their own impulse. SA node can do it, AB node can do it, and bundle of His can do it. But the rate of generation of this impulse is different. The rate of generation of cardiac impulse is highest in SA node and lowest in bundle of His. So as a result of these, since SA node is having highest, मान लो SA node, AB node, bundle of His. Now she is making impulse very fast. In 1 minute, say 80. And she is producing 1 minute 60. And she is producing in number of impulse how many? 40. 80, 60, 40. For each impulse generation, she will take less time. Before she completes generation of one impulse, she will transmit this impulse to her. Now, she will act according to this impulse, not by her own, because it is yet to come. Same thing will happen to her. Before she generates her impulse, then she receives the impulse coming from her. Before that, as a result, when all these three pacemaker cells are normally functioning, but they will not function normally. Only they will beat, they will produce impulse according to the SA node. In absence of SA node, suppose SA node is destroyed, in that case, AB node will come into action. Now your heartbeat will beat according to the pace she is generating cardiac impulse. According to that pace. If again she is destroyed, then the heart will beat according to this rate. Okay? Now the rate of impulse will be around 40. So with 40 cardiac beat, it is very difficult to survive. So this is the thing. So they produce, in our next class, we will discuss how this property of the cardiac muscle is called automaticity. This is called automaticity and rhythmicity. This generation of impulse is having a rhythm. When there is disturbance in rhythm, we call it arrhythmia. It's a disease only. Irregularity of heartbeat means it is arrhythmia. Okay, so these as nodes, they produce cardiac impulse rhythmically, and they produce this automatically. It is their inherent character. Nobody is stimulating them externally. So something is there within the cell. We know all other cells, they are to be stimulated. Either nerve will stimulate it, or it will be stimulated by any other external sources. Then only they produce action potential. But these pacemaker cells, they don't require any external cells for their activity. However, their actions can be modified by our nervous system. They can increase, decrease their activity. They can increase, decrease their conduction. Increase their conduction, decrease their conduction. The nerves, sympathetic and parasympathetic nerve, they can increase and decrease our excitability of the cells. They can increase, decrease the conductivity. They can increase, decrease the automaticity. They can increase or decrease the contractility. So all these are having 4 effects. The nerves, our parasympathetic and sympathetic nervous system, they can modify the activity of the heart muscles. They can modify the excitability, they can modify the automaticity, they can modify the rhythmicity, they can modify the conductivity, they can modify the contractility. Okay. So these junctional tissues are supplied by particularly the right coronary artery supply all except LBB, late bundle branch. See, this is late bundle. Actually, bundle of his is divided into 2 more branches. These are left bundle branch going to the left, and the right bundle going to the right. Okay, so this LBB is supplied by both. All other junctional tissues are supplied by RCL. Now, left coronary artery. Left coronary artery, it originates from posterior aortic sinus. So there are 3 sinus. One is for posterior, another is left anterior. So that from that left coronary artery arises, and from here it is left coronary artery. From that is right coronary artery arises. Left coronary artery, it is larger than the right coronary artery. It originates from left posterior aortic sinus of ascending aorta, and they run in between trunk of artery and pulmonary trunk and auricle. Anterior, it is having 2 important branches. One is anterior interventricular artery and the circumflex artery. So this is your heart. Here is the heart. So most of the anterior surface belongs to right ventricle. Part of the left ventricle you can see from anterior side. Okay, most of the ventricle remains at the back. Okay, so in between the right and left ventricle there is a groove, interventricular groove. So one branch, this anterior interventricular artery, and the other branch will move to the through this groove will go to the through this coronary sinus will go to the back, and this branch is called circumflex artery. See this artery, that is the circumflex artery from the back, and this is what? This is coming down in between the both ventricles. Okay, here's the groove. Now while passing, they are producing several branches and supplying the apex. So these are the main 2 arteries, and the branch of the anterior interventricular artery. Actually, this is one. This is one, and then LAD is the second. LAD means. You remember, it has got another name, but it is more commonly known as LAD, and in the reports, angiography reports, or in echocardiography report, it is mentioned. So there is ischemic changes in LAD region, or there is obstruction in LAD. So this is mentioned. Okay, so that's why it is also very important. And then the left circumflex artery, diagonal branch, left marginal artery, and septal branches. So these are the different branches of the coronary, left artery, and now the areas of distribution. So these are the remaining area is supplied by left coronary artery. Okay. Venous drainage. So I will not discuss in detail because this is physiological, it is less important. And here there are two venous system is there. One is the superficial venous system, another is deep venous system. Superficial venous system has three components. One is coronary sinus, great cardiac vein, and anterior cardiac vein. And deep venous system is having three vessels, veins. These are the arterial, sinusoidal vessel, arterioluminal vessels, and Thebesian vessels. Through these, all the artery is supplying some blood. This blood is again coming back to the cavity of the either auricle or the ventricles. See, coronary arteries are end arteries. मतलब end arteries मतलब No. Normally what happens, one artery, it produces arterioles, then again it produces number of capillaries. So it ends in capillaries through formation of capillaries. Okay, that's what we call it. Then from these capillaries, the venous end of the capillaries will be formed, then venule will be formed, then vein will be formed. So this is end arteries, means artery, arteriole, and capillaries. Now, if any branch from other artery joins with this artery, particularly one, they never join. Normally, one artery never join with another artery. If they join, they are called collaterals. Suppose this is the septum of the heart, interventricular septum. So one branch is supplying this area. One branch is supplying this area. Now, if another branch of artery is also coming to supply this area, either they may join together and they supply. This sort of junction, this sort of circulation is called collateral. The capillaries of this artery and capillaries of they can also join together. They are also called collaterals. They are also called collaterals. But normally you will find no collaterals. You will find they are all end arteries. But you will find there are also some collaterals. But these collaterals are not anatomically, these are present. But physiologically, they are absent, means they are not functioning. These collaterals, though present, they are non-functional. Then what is the use? Then what is the use? Of course, they are having use. When your cardiac muscle cells are in crisis. In crisis means blocked, partially blocked. There is ischemia, development ischemia. Ultimately, this may lead to infarction. Total block is infarction. So, when this ischemic change starts, collaterals also starts to become activated. They gradually become active so that area doesn't die. That area doesn't die. So these collaterals are also called, there is another word for this, anastomosis. They are the anastomosis. Anastomosis, the collaterals normally doesn't exceed. It is there, but it is anatomically, presence is there, but functionally it is not there. Okay, it becomes functional when there is any block. Understood this point? Okay, fine. So one of the feature of this coronary circulation is these arteries are end arteries. Normally, these are ended. This is one of the important feature, See, you may face some questions now regarding your exam. What is this? Some questions may come. You may face this sort of question. What are the peculiarities of coronary circulation? Peculiarity. Or what are the special features of coronary circulation? So what are these features that I will explain one by. That is important part for you. So one important feature you already came to know. What is this? End arteries. They may have collaterals or
an artery and
anastomotic channels, but this is functional only when during ischemia, formation of ischemia, or during just immediately after. These are formed just immediately after infarction developed. So motive is to make this area survive, for its survival, whether it's there in. If it is generated, then area will be regenerated. Otherwise, it will be degenerated. See, during these collaterals, which are existed in between the arteries, they are non-functional, as I said. These are from within the coronary artery, but they can have collaterals from outside the heart. Extracardiac anastomosis. See, your bronchial artery, they can also supply your heart through the bronchial arteries. They can develop anastomosis, cardiac anastomosis. They can join with the cardiac coronary arteries, and through that it may supply some amount of blood. It may have bronchial arteries, phrenic arteries. You know what is phrenic artery? This artery supplies your diaphragm. Okay, so they can also give collaterals to the coronary arteries. Internal thoracic artery, vasa vasorum. What is vasa vasorum? Vasa vasorum. Okay. The arteries or blood vessels, arteries or veins, vessels, blood is going through the lumen, but this blood they are not using for their own nutrition. So they, like heart, they must also have some blood supply there all. They are also having some muscles. Muscular coat is there, isn't it? Tunica media. Tunica media is made up of muscles, smooth muscles. So these smooth muscles, for their functioning, oxygen is needed, nutrition is needed. Who will supply this? The vasa vasorum. The branch of this vasa vasorum can also supply the heart. Okay? So vasa vasorum of the aorta, vasa vasorum of the pulmonary arteries, they can form anastomotic channels. Another thing is important, another important characteristics is, sir, which artery, left coronary artery or right coronary artery, which is dominant? Means which artery is supplying most of the heart, part of the heart, which is dominant. Okay, so somebody may tell, sir, it is right coronary artery, somebody may tell it is left coronary artery, somebody may tell, sir, both. Okay, now how we will determine? How we will determine? We will determine it by this. What is this? This is at the posterior. In between the ventricle, both ventricles, there is a what? A group. So one artery is passing through this. PDA. PDA is passing through this. See this, who is right or left, who is supplying this PDA? This will determine who is dominant. Okay? Now, if it is supplied by both, this one as well as this one, then we call it codominant. And this is present in 10 to 20% people. In 10 to 20% people, there is codominant. Both right and left, both are equally dominant. And mostly, these are, in most of the people, these are supplied by, what is this? Right. So, what is the percentage of them? It is nearly 50 to 60% people are having this. And rest of the people are having left atrial, left dominance, left coronary artery dominance. I already told, larger arteries, coronary, either it is left coronary artery or right coronary artery, they remain superficial in the epicardium. And their diameter is, and they are, flow is easy flow through them because they are having low resistance. A minimum resistance is there. So good flow. But this one. This is either right coronary artery or right coronary, one of the artery, lying in the superficial layer, that is epicardium. So here the vessels are wider and they are having low resistance. Now they are producing branches, producing capillaries. These capillaries are entering within the middle layer. Okay, and some of their branches coming down to this layer. What is this layer? Subendocardial layer. And now you can see these branches are joining. Number of vessels are there. They are joined together. These are called plexus. These are called plexus. These arteries, going to the inside, and in subendocardial region, they produce plexus. So plexus means aggregation of some blood vessels. These are vessels. It may happen in case of nervous system. Some axons may come together, stay together and form a plexus. Similar plexus you have studied already. Yes. Meissner's plexus or Beckley plexus. Okay, these are actually not blood vessels. These are what? These are actually axons. Some axons grouped together, joined together. Now see another important aspect. What is this? This is the wall of the ventricle, wall of the heart, wall of the ventricle. Forget it. Relax, relax, relax. His bicep is relaxed, and we know this biceps has to get blood supply, oxygen, nutrients. So some vessels are passing through the muscles. Okay? So now easily Hello, look at this. Now easily blood is passing through the muscles. Through the muscles. Now he is contracting this, squeezing this. Now what will happen to the blood vessels?
Contract.
What will happen to the blood vessels?
Muscles will block the muscle will.
What will happen to the blood vessels? This is the muscle and this is the blood vessel. Okay? Now what I am doing? I am compressing the muscles. What will happen to this? This will also be compressed. This will also be compressed. Isn't it? As it is a flow, will be reduced. What will happen to here? When the myocardium contracts this way and that way, this way contracts, this way also contracts. As a result, what will happen to the blood vessels within? They will be constricted. The lumen will be narrowed. And what will happen to the flow, blood flow? Will be reduced. Okay, fine. You understood this. Now tell me, when they become this contracted, constricted during systole of the heart? Now tell me, during systole, blood flow will be increased or decreased?
Decreased.
But in other organs, during systole, blood flow is increased. But here it is the difference.
And diastole.
During systole, blood flow to the myometrium is decreased. And opposite, when it is in diastole, blood flow is increased. So it is in contrast to other organs. During diastole, blood flow is increased. During diastole, so in cardiac muscle, blood flow is phasic. Blood flow is phasic, meaning during diastole, flow is increased and during systole, flow is decreased. How we can explain this? Main function of the heart? Pump. How it pumps blood? Through systole and diastole. Systole means contraction of the ventricles or auricle. Contraction of the auricle sends blood to the ventricle. Contraction of the ventricle sends blood to the aorta. Pulmonary artery and aorta. Okay? So during each systole, during every systole, every ventricle, two ventricles, each ventricle is pumping some amount of blood into circulation. During every beat of the ventricle, some blood is coming out, entering into the circulation, into the aorta. Every beat. Some amount of blood is coming out from each beat. What is this called? This is one stroke. So during each stroke, means each systole, some amount of blood is coming out. This volume of blood that is coming out of the ventricle, from each ventricle, is called stroke volume. Stroke volume. Now tell me, what is stroke volume? And after you, then Uday. Another. And he will be answering. You get ready.
After the
What is stroke volume?
after systole, the amount of blood pumped from the heart is systole. It's
From the heart into the circulation.
circulation.
Yeah.
Is stroke.
This amount of blood is called
Stroke
stroke volume. Okay, sit. Now you tell me, how much blood you can eject in 1 minute? How much? Normally it is 70 ml. If I ask what is your normal heart rate, you tell what? 72 beats per minute. Okay. What is your normal hemoglobin content? You tell 14.5 or something like that. But it is the mean value, average value. There is a range. Normal, you learned there is a range. So in heartbeat, there is also a range. Anybody know what is the range?
72 to 100.
No, range.
60 to 80.
See, 72, okay, it is the average value. Then what about 70? It is low or high? 80, it is low or high? 85, it is low or high? 70, it is low or high? 65, it is low or high? What is tachycardia, bradycardia? Increased heart rate. Okay. So your normal heart rate, you said it is 72. So it is increased to 80. Can you call it tachycardia?
No.
Why not?
There should be a range.
It should be beyond 100 beats per minute. It should be beyond 100 beats. And it should sustain. এটা সবসময় থাকতে হবে। আমি যদি এখনই একটু দূরে আসি, my heartbeat will be more than 100. So you cannot tell I am having tachycardia. But this increased heart rate to be sustained. So if somebody is having sustained tachycardia, sustained increased heart rate, then we call it tachycardia. And bradycardia? Decrease. Beyond?
70.
Or?
60.
Or?
50.
50. Okay. So this is bradycardia and tachycardia. Fine. So now 85 beats per minute also normal, 60 also normal, 55 also normal. Okay. So this is the normal range. Okay. Now every beat is having a stroke volume that is the 70 ml. Now my question is, in 1 minute, how much blood you can eject? In every beat, you are sending 70 ml. In 1 minute, how much you can send? It depends on your heart rate. Your heart rate. Now, if your heart rate is 75 and your stroke volume is 70, what will be the cardiac output per minute? 70 ml into 5 approximately 5 liter. So our cardiac output per minute is 5 to 6 liters normally. 5 to 6 liters. Okay. Okay, we understood this. Next point. If your heartbeat is 75, means in 1 minute you are having 75 beats. Now can you tell me how much time will take for 1 beat?
1 divided by 1 by 60.
1 by 70.
I said 7. My heart rate is 75.
1 by 70.
Why 1 minute? और इसको सेकंड में कन्वर्ट करो. See, then you will answer will be in second. 0.8 second. Huh? 1 beat will take how much time? Normally in 1.8 second, 1 beat is occurring. So out of this 0.8 second, ventricle uses 0.5 second for diastole and 0.3 second for systole. This is time. Systole, diastole. Systole is smaller, having less time. Diastole is having more time. Now it is clear to you? During cardiac cycle, normal cardiac cycle is 0.8 second. Means one cycle completed in 0.8 second. And out of this 0.8 second, ventricle takes 0.3 second for systole and 0.8 second for diastole. Okay. Now see another point. Cardiac output. How much? 5 to 6 liters. Okay. Per minute. And our heart, out of this, is a 5 to 6 liters of blood coming out of the heart, circulating throughout the body. Where this blood is going? Throughout the body, some part is coming to brain, some part is going to skin, some part is going to GI tract, some part is going to kidney, this way it is distributed, some part is to the muscles, and some part will be distributed to the heart muscle. How much out of this 5 liter, how much this heart is getting? 225 ml. 225 ml per minute. Okay. Now our heart is having a weight of 300 gram. Now per gram, how much blood it is getting? 225 divided by 225 in 1 minute. 225 divided by 300 gram. Then per gram how much blood it is getting? Around 70 to 80 ml. Gram, what? 225 ml divided by 300 gram. That is per gram how much? The result is nearly 70 to 80 ml. Whereas other tissues, per gram tissues, they are getting 4 to 5 ml. Other tissues are getting. So its consumption, its requirement of blood is per gram is much more. Because why it is more? Because it has to supply more oxygen, more nutrients. It has to wash out the metabolites, carbon dioxide. So that's why more and more blood has to be perfused. Okay. Now see, coronary blood flow ml per minute. So we calculated, we said 225 ml. So this is approximately 225 ml. End of systole. Then again diastole will start. And this is part is actually diastole. So during diastolic part, from 225 it is coming down. During systole, we said during systole what is happening? Blood vessels are squeezing. So less blood will be passing. So that's why flow is reduced during systole. And when it started diastole, blood vessels are widening, so flow is rising. Then gradually it will fall. Then gradually it will come to this value, to normal value. Now again it will go to systole. So we can see the flow of coronary blood flow is phasic. During systole it is less, during diastole it is more. Is it clear to you? Fine. So this is another features to you. For the the first point already I described. 5% of total cardiac output, that is 225 ml per minute. This is what? one of the important features of the coronary circulation. Second part, dominance, already discussed. Dominance, which either it is left coronary artery or right coronary artery. Dominance we have already discussed. And third point. Okay, let's describe this. Try to understand this. Third point. What do you mean by oxygenated blood or deoxygenated blood? What do you mean by deoxygenated blood?
Carbon dioxide mixture of
Deoxygenated blood, does it mean there is no oxygen?
presence of oxygen. Oxygen is present.
Oxygen is there, but less compared to artery. Okay. How much oxygen is there in the arterial blood? How much oxygen is there in the arterial blood? 14 ml. 13 ml. How much oxygen is there in your arterial blood?
Values according to hemoglobin.
Okay. Use your background knowledge. I'm telling you. Your 100 ml of blood is having certain amount of hemoglobin. What is this amount? 15 gram. Okay? 100 ml of blood. Having 100 ml of blood, it is having 15 gram of hemoglobin. We know 1 gram of hemoglobin can carry 1.34 ml of oxygen. Now you tell how much your 100 ml of oxygen, blood can carry oxygen. That is for 15 gram of hemoglobin into 1.34 ml. This will be around 19 to 20. So your blood can carry near about 20 ml of oxygen. When this blood comes to the periphery and supply oxygen and comes back, then it will be having less oxygen. How much less? 14 ml. Near about 5 ml will be taken up by the tissues. Okay? And the minus 20 ml minus 5 ml or 19 ml minus 5 ml? 14 ml. So in the venous blood, you can have 13 to 14 ml of oxygen. Okay. What is the situation in your heart? When 100 ml of arterial blood is passing to the myocardium, it will extract near about 80% of the oxygen from the arterial blood. So if you are having 20 ml and if it is 80% is extracted, that means how much extracted? 16 ml. So 15 to 16 ml is extracted. So how much will be retained in the venous blood? 5 ml. Whereas in other tissues, in the venous blood, what is the content? 13, 14. So every difference here is in other tissues, it is 20. Difference 19 or 20 minus
5.
this, only 5. Whereas in cardiac tissue, much high, difference is much high. That means extraction power of oxygen, power for oxygen is much more in cardiac muscle. It needs more oxygen. So that is another speciality of cardiac muscle, of coronary circulation. Okay. Coronary blood flow is closely coupled to cardiac metabolism. How you can explain this? Means if the metabolic rate is high, If the metabolism in cardiac muscle is high, then cardiac flow, coronary blood flow will also be high. Okay? Let us understand this. Cardiac muscle is working. So it is lot of metabolic reactions going on, and lot of ATP has to be produced. So more oxygen will be required. So higher the oxygen requirement, higher will be the blood flow. Metabolic demand is more. Your heart rate is 80. Now you have started exercise, your heart rate became 160. Now its demand will be more. So more oxygen you require because you will be performing this contraction using the ATP. Okay? So a lot of ATP has to be produced. So for this production, lot of oxygen has to be produced. So for this purpose, a lot of blood flow to be made in the coronary myometrium. This is one thing. Another important thing, there will be increased production of metabolites, end products, metabolic end products, like lactic acid, P substances, ADP, adenosine, AMP. So these metabolites will be accumulated. And these metabolites needs to be washed out. So these metabolites can have direct effect on the blood vessels, coronary blood vessels. What effect? Vasodilating effect. So this, when there will be deposition of these metabolites, they will cause vasodilatation. So vasodilatation means more flow. Why I have increased this flow? To wash away these metabolites. Now this, when the flow will be increased, now this will be washed away. Again, the blood flow will come to the normal value. And this, another important feature you have to explain, auto-regulation of coronary blood flow. Heart muscle itself can regulate its flow. When it is decreased, it can increase it. When it is too much increased, it can decrease it. And the range is 60 to 160 millimeter of mercury pressure. If your coronary arterial blood supply is reduced to 160 millimeter mercury, then what it will do? It will make some change. There will be accumulation of metabolites. This accumulation of matter will cause vasodilatation. So more blood will be coming. So blood flow will be increased. So in this way it can do it. Again, if blood pressure is increased, blood vessel will be dilated, vessels will be dilated. Dilatation of blood vessels means stretching of the smooth muscles. And when the smooth muscles are too much stretched, they will reflexly cause vasoconstriction. Overstretching, vasoconstriction. Overstretching, vasoconstriction. So overstretching, more flow, vasoconstriction, flow will be coming down. So this way, there are two theories. One is myogenic theory. This is myogenic theory. When muscles are stressed, they will reflexly cause vasoconstriction. This is the myogenic theory. And metabolic theory means when metabolites will be depositing, they will cause dilatation of the blood vessels. So more blood will be now coming and they will wash away the metabolites. Again, there will be withdrawal of this vasodilating effect. So again the blood vessel will be coming. In this way, they can increase, decrease the blood vessels. Thereby, increase, decrease the coronary blood flow. So 5 point is autoregulation. Coronary blood flow is phasic. It is already been discussed. And coronary blood vessels are end arteries. It is also been told. They might have collaterals. These collaterals are formed normally not present. And they are present, they become existed if they existing during emergency. So that's all for today.